Welcome to part 2 of the lecture Immune Deficiency. Here in this part, we're going to discuss the other groups of primary immune deficiency. May I remind you with the first part where we discussed the combined T cell and B cell immune deficiency. Here I'm going to discuss the second group, the predominantly antibody deficiency, with the characteristic features of this group. The onset of symptoms is usually after the age of 6 months. If you remember, in the group 1, the combined T and B cell deficiency, the onset of symptoms was before the age of 6 months. There is recurrent bacterial pneumonia with encapsulated organisms, strep pneumoniae, Haemophilus influenzae. Usually they get bronchiectasis due to chronic lung infection, repeated gastroenteritis episodes, the meningoencephalitis, and here especially the enteroviruses, because the group of predominantly antibody deficiency, they mount very well with the viral infections except the enteroviruses. And one virus very important in this group is the poliovirus. So sometimes these patients develop polioencephalitis. And even after the administration of oral polio vaccine, they develop the paralytic polio due to the vaccine. Also, this group is liable to have autoimmune diseases and malignancy. Here I'm going to give you examples of predominantly antibody deficiency. The first disease is X-linked agammaglobulinemia, the XLA or Bruton disease. Here we have the maturational arrest of B cell precursors. So no mature B cells and absence of all immunoglobulins, the IgM, IgA, and IgG. The second one is transient hypogammaglobulinemia of infancy, in which we have maturational delay of B cells, but they will develop later. It is common in preterm infants. There is normal count of mature B cells and low levels of in all immunoglobulin classes. The B cell will resume their function by the age of 4 years. The third disease is common variable immune deficiency disease. There is normal B cell count, low levels of all immunoglobulin classes that persist after the age of 6 years. The last one is selective IgA deficiency. This is a mild form of immune deficiency with an incidence of 1 to 300. The only abnormality is absent IgGA. Now we come to the third group, the defects in phagocyte number and or function. And here we have the qualitative defects, decrease in number of neutrophils, like the severe congenital neutropenia, where we have the absolute neutrophil count less than 500 per cubic millimeter. Or we get a qualitative defect. Here the defect is in the function of the neutrophils, like the leukocyte adhesion deficiency and chronic granulomatous disease. The characteristic features of this group is that the onset of symptoms can occur at any age, with the characteristic clinical features of recurrent bacterial and fungal infection. Here, the bacterial and fungal infections are the predominant infections. You get skin and deep organ abscesses in the lung, liver, spleen. There is chronic gingivitis, periodontitis, and mucosal ulceration. And here, when we mention the decreased number of neutrophils, we have to say severe congenital neutropenia, which is inherited as either autosomal recessive or autosomal dominant. Severe congenital neutropenia is considered when the absolute neutrophil count is persistently below 500 per cubic milliliter in the absence of secondary cause of neutropenia, like infections, drug, autoimmunity, and malignancy. Here you can see in this photo the aphthous stomatitis that is characteristic of the severe congenital neutropenia, and as well as the infection of the skin with ulceration. For the phagocytic function disorders, we have first the leukocyte adhesion deficiency. This is an autosomal disorder that results from the inability of the neutrophils to adhere to site of infection. So when there is infection, usually the leukocytes adhere to that site in order to get diapedicus through the endothelial wall to the site of infection to engulf the microbe. So if there is no adherence, the neutrophils will not get into the site of infection. And that's why we can see that there is lack of pus formation at the site of infection. As you can see, this is here the girl with an abscess and the draining lymph node is also swollen. You can see that the aspirate of this abscess reveals serosanguinous fluid, not pus. There is severe dental affection as well, and perianal with perirectal abscesses, delayed separation of the umbilical stump. Usually the umbilical stump falls by the 10 days or 2 weeks, but here they persistent delayed for more than 1 month. There is poor wound healing with disfiguring scar formation, and the hallmark here of diagnosis is that the leukocytosis, we get the neutrophil count above 20,000 per cubic milliliter, and this is a pathognomonic sign. The second disease in the group of phagocytic function disorders is the chronic granulomatous disease, the CGD. Here, there is inability of phagocytes to generate oxygen radicals that are essential for the intracellular killing of bacteria and fungi. The mode of inheritance of this disorder is either autosomal recessive or X-linked inheritance. The cardinal features are abscesses all over with granuloma formation. This is an abscess on the arm of a child, and the granulomas, as you can see, in the lungs. The granuloma is very characteristic. You can see in the arrows here, these are the sites of granuloma in the lung. It can occur also in the skin, the liver, and GIT. In this disease, there is normal neutrophil count, but the defect is in the intracellular killing of the bacteria and fungi. The last is the complement component deficiency. The onset can be at any age with pyogenic bacterial infections in the skin and deep organs. There is recurrent Neisseria infection. The Neisseria meningitis can happen several times in the same patient. And there are also autoimmune diseases. Here you can see the abscess on the neck and on the limb of a child. The group is the combined immune deficiency with associated syndromic features. We have the DiGeorge syndrome, the Wiskottaldrich syndrome, and the hyper-IgE syndrome. Here we have DiGeorge syndrome, there is deletion in the area 11.2 on the long arm of chromosome 22, which results in defective embryogenesis of the third and fourth branchial arches, which give rise to the thymus, the parathyroid, and the trunk of the heart. So usually these patients present with absent thymus. As you can see here in the lateral X-ray, you have the superior mediastinum empty of thymus. We have conotruncal cardiac defects, neonatal hypocalcemia, dysmorphic facial features, like you get the hypertelorism and the nasal bridge. You get this long philtrum, which is the area between the nose and the upper lip, and the receding mandible, which all gives rise to the appearance of a fish-like mouth. There is also defect in the auricles of the ear. You get a cauliflower ear auricle. There is speech delay and mild lymphopenia, mainly the T helper cells. The Wiskottaldrich syndrome, the WAS, this is an X-linked disease, and there is recurrent pyogenic infection with congenital thrombocytopenia and small platelet volume with bloody diarrhea in the first month of life, together with eczema. So any boy with eczema, with recurrent infection, pyogenic infection in the skin or anywhere, together with thrombocytopenia, this is characteristic for the diagnosis of Wiskottaldrich syndrome. There is high incidence of autoimmune manifestations and malignancy in this disease. The last is the hyper-IgE syndrome, which is inherited as either autosomal recessive or autosomal dominant. Here there is atypical eczema, and we mean by atypical eczema that occurs on the extensor surface of the limbs, unlike the typical or the atopic eczema, which usually found on the flexure surface. There is recurrent pneumonia, nematoceles due to staph pneumonia. This is diagnostic to get a nematoceles and the high incidence of staph pneumonia. There is coarse facial features in the form of broad nasal bridge, prominent nose and jaw. The skeletal anomalies in the form of scoliosis, osteoporosis, overcrowded teeth due to delayed shedding of milk teeth. So you get the milk teeth together with permanent teeth in the mouth. There is high serum IgE level, above 1,000 international units per liter, and this is diagnostic too.